I usually go out a couple of times a day.
I was playing golf course. That's perfect.
They're renovating that.
Is that what they had in the room? It's the first time here to happen.
Yeah, Lord. Total renovation of the golf course they started today, yesterday. Yeah, they're probably done. That's why they started right after this one. They got a year.
I've had some membership with the company.
Yeah, that's how I played out there. They used to have my guy, this Erik, got me out there 3 times played out. You just have to walk, huh? It is beautiful. It was nice going there, going to the just the experience going there. I mean, the lawn, you got Zoya, you, I got that's what I got. Here's some there, right? Make a noise.
How are you? Good. I did it was me. Well, I saw you sitting next to us, so that was I gave it away. Nice to meet you. Thank you for bringing everything.
Oh, you're welcome. I hope it works out.
Yeah, I think the people appreciate it. They can take it with them.
Yeah.
Read up on it.
Yeah.
Okay, good afternoon, good afternoon. Welcome, everyone. Welcome to our hybrid audience. I want to say good afternoon to our in-person audience and our 130 plus people online right now. So happy August. It is the last Tuesday of August. And if you joined us, whether you began with us back in 2020 when we launched Emory Brain Talk Live, or this January where we decided the fourth Tuesday or the last Tuesday, depending on the availability of our presenters, we would offer a hybrid option because people still want to meet in person, right? And it's just a great opportunity to fellowship and connect and see you face to face. So in January of this year, we launched this program so it could be hybrid because we want to put our arms around you and again, welcome you on site to the Brain Health Center. Today, we have a very special program for you, and I'm just going to do a little bit of housekeeping before I turn it over to Dr. Monica Parker. But this is what we're referring to as a town hall meeting. So if you're here on site, take lots of notes. If you're here with us virtually, we want to admonish you to grab a pen and paper because we're going to go over a lot of information and some of the questions that you may have had or you need clarification about, we will definitely address those today, okay? So in the past, we've always begun with exercise. We practice what we preach, but today we want to dedicate this full hour to answering your questions related to this new drug and to help you really dig deep, dive deep, and have a better understanding of how you can access the drug, who's the drug for, what it could mean for the future state of healthcare. And so today we're going to skip John. That doesn't mean you need to skip any exercise, right? He gets us going, and he's been rocking and rolling with us for half a decade or more. And so we don't want to say no exercise, just today is solely dedicated to understanding this new drug. Okay, is that all right? All right, so with that said, I'm going to turn it over to our illustrious outreach director, Dr. Monica Parker. She's a geriatrician and has been practicing for over 30 years and has been leading this outreach effort here at Emory University for 20 years. Welcome, Dr. Monica Parker.
Thank you, everybody, and thank you to everybody who's in our room. Thank you to everybody who is joining us online. I just want to say that this is the last Tuesday in August, so it means our summer is officially over. We will be resuming all of as many in-person events as possible, starting with our big forum on October 24th, 2023 at the Carter Center. We're still assembling our lineup, but you know, this is one of our signature outreach events. Carter Center Library, Tuesday, October 24th, 10 to 1 p.m. Put that in your notebooks, and as soon as we get everything confirmed, we'll be sending you some communication. And as Mrs. Dorbin, our co-director of our outreach, recruitment, and education core here at the Goizueta Alzheimer's Disease Research Center, we will be resuming every fourth Tuesday an in-person event here on campus, as well as visiting with you online to bring you more information about brain health programs and opportunities to participate in clinical research here. So one of the reasons we do the Brain Talk Lives and we do our semi-annual forums is to make you aware of what constitutes healthy aging, what is helpful for aging, and more importantly, how you can preserve cognitive function or brain function, or how you remember things, your memory, as you age. All of us want to age well, not only physically, but also cognitively in terms of how we remember things, how we're able to do things, and use our brains to remember our family members. So part of our outreach is educational to help you, inform you about opportunities to do that, but also about what you need to do to keep your brain healthful. So here at the Goizueta Alzheimer's Disease Research Center, our end game is getting your participation in clinical research here. Clinical research is not just a drug trial to test a drug. We're going to hear about one of the new FDA-approved drugs today, but there is other research that we do here. We do research in behaviors, dementing behaviors. We do research that has to do with different kinds of testing or diagnostic tools to use to evaluate people who have dementia. And the people we're looking for most commonly in our research center right now are people who are upright and healthy and highly functional. If you are dysfunctional or you have a relative who is suffering from end-stage dementia, there aren't very many clinical research studies that are appropriate for them. So we want to preserve our brains, we want to preserve our bodily function, and the more we participate as healthy people and get studied and followed over time, the better we are going to be at discerning and better picking up people who may have cognitive problems or problems with their memory. So today, one of our cognitive neurologists, Dr. Erik Johnson, is going to talk to us about this drug. A couple of months ago, he came to talk to us about this drug. It hadn't yet been approved, but we've got a lot of questions about Leqembi and drugs like Leqembi, and is this for me? So if you heard anything before, when we've talked about brain health before, we know that there are many different types of dementia. There's Alzheimer's, most commonly diagnosed in terms of pathology, followed by a mixed dementia, which can be Alzheimer's with vascular or something that relates to like stroke-related dementia. There's an HIV dementia, there's alcoholic encephalopathy, there's chronic traumatic encephalopathy or brain damage that or memory loss that occurs because of trauma to the head. Those are not the kinds of things that Leqembi treats. So it's really, really important for people to understand who these medications are appropriate for and who they're not appropriate for. At this time, I'd like to introduce to you Dr. Erik Johnson, one of our cognitive neurologists. You've met him before. We bring him back. We're happy that he's here to volunteer his time and tell you exactly how we evaluate people, what's going to be necessary in order for people to get this medication, who needs it, who doesn't need it, etc. Yes. Dr. Johnson.
All right, I want to make sure I can be heard online, because I know there's an audience here online. Thanks, Dr. Parker, for the introduction. I'm happy to come back to Brain Talk today to discuss lecanemab. It's an exciting time in our field, and we're, as providers, very excited to be able to offer a new treatment for Alzheimer's disease. But there are a lot of questions that people have about it, and that's what we're going to talk about today and try to address as many as possible. I'm going to try to leave time at the end of the presentation for your questions. So if you have them, hang on, and hopefully we can answer them at the end. So this is the PowerPoint slides that I'm going to show. We are actually using in our clinic to provide to patients on virtual meetings to give them some additional information about lecanemab and if it's something that they might be interested in. I've adapted some of these slides, most of which were put together by Dr. Hales for this particular presentation for Brain Talk Live. But if any of you have participated in one of those sessions, some of these slides may look somewhat familiar. So the outline of today is, well, I'm going to give a few high-level comments about the lecanemab and the state of the field. We'll talk a little bit about lecanemab and how it works, how it's delivered, what it does, who should be treated, what are the potential side effects, what is the cost, and how long do you have to be treated with it, and then end up with a summary. So we start here with the fact that Alzheimer's disease is really a devastating illness. It is something that many people are suffering from these days, and more people are suffering every year because it's a highly age-related disease and more of us are getting older and getting Alzheimer's disease. And it's not only difficult for the patients, but also for their families or the caregivers for Alzheimer's disease patients. So we all want a treatment that helps the disease, prevents the disease, slows the disease, stops the progression completely, or reverses the disease. That is our ultimate goal. Ultimately, we want to prevent the disease. We don't want anyone to have Alzheimer's disease in the first place. So lecanemab is the first medication that has been shown to convincingly slow disease progression. So that's what we're talking about. We're talking about a medication today that slows down the disease. It doesn't prevent yet, doesn't stop or reverse the disease, but it slows the progression. So that's a big deal. We've known about Alzheimer's disease now. It's been described for over 100 years. 1908 was the year Alzheimer's was described by Dr. Alzheimer. And we have not had a treatment that actually affects the underlying disease process, a medication that affects the underlying disease process until now. So it's an exciting time. I feel privileged to be able to practice cognitive neurology now in such an exciting time in the field. And there will be more to come. This is the first step. So I think it's important to understand what we're dealing with here with lecanemab, what it does do, what it doesn't do, and what we can look forward to, hopefully, in the future. So this is the other comment I'd like to make, and this is what I tell many of my patients. There are very few free lunches in medicine. So almost every decision in medicine involves a risk versus benefit decision. And lecanemab is no different. That's the same as if you're going to take aspirin or Tylenol. There is always a risk versus a benefit. And we know that lecanemab does carry some risk. So for patients that are eligible for this particular medication, it's important to understand what the risks are and what the potential benefits are so that you can make a decision whether it's right for you, because that's a personal decision made in consultation with your healthcare providers. It's not going to be right for everybody. So this is what we're talking about today. We want to give you some information about the risks and benefits and what we don't know about lecanemab. So what is lecanemab? Lecanemab is an antibody. So what is an antibody? An antibody is a protein made by your immune cells that binds to other proteins and tags them as something that the immune system should recognize as a foreign substance and do something. That's what an antibody is. So this is a lot of technical information. It's a humanized immunoglobulin gamma-1 monoclonal antibody. And what this protein does is that it binds to a protein called amyloid beta, A-beta. And A-beta is something that accumulates in the brains of people that have Alzheimer's disease, these things called amyloid plaques. And that is actually one of the ways we define the disease, is the presence of amyloid beta plaques in the brain and also cognitive impairment. So lecanemab targets amyloid beta in the brain. And amyloid beta in the brain eventually will lead to some cognitive problems, brain atrophy. Here, looking at the hippocampi. If you look at the brain under a microscope, and this is actually what Dr. Alzheimer's did over 100 years ago. If you look at the brain with someone with Alzheimer's disease under a microscope, you see all these things that are stained here in brown, and these are amyloid plaques. These are accumulation of the amyloid beta protein into insoluble substance, something that doesn't float around in the brain. It's clumped together into these things called plaques in the brain. So this is not normal. Young people that don't have Alzheimer's disease don't have these plaques in the brain. And these become more common as people grow older. And everyone who has Alzheimer's disease, as we define it, has these plaques in the brain. And we think these are detrimental to brain health. Now, recently, I will say in the last 10 to 20 years, 15 years, we are now able to assess whether someone has amyloid plaques in the brain while they're alive. We don't have to wait until they pass away and look at the tissue underneath the microscope. We have ways to assess for amyloid plaques in the brain now, and that's through something called an amyloid PET scan, where we put a molecule in your blood that binds to these plaques, and then we can look at that signal on a scanner. And here on the left is someone who has a lot of amyloid beta plaques in their brain. And here is that same person who has been treated with lecanemab in a study called the AHEAD study, So this is where this picture comes from. And you can see that there is less red on the right than there is on the left. And that's because this medication has cleared a lot of the plaques in the brain, especially in the cortex. And this particular molecule will sometimes bind deeper in the brain. That doesn't mean that there are plaques there. That just means that there's binding. But this is one way to assess for plaques. We also do something called a lumbar puncture. And we can take spinal fluid from your back and send it to the laboratory to assess whether there are amyloid plaques in the brain as well. And we do that quite often here at Emory because it's a good test. It gives us a lot of information, and it happens covered by insurance, and amyloid PET scans are not currently. So lecanemab, you can think about it as really a medication that tries to scrub amyloid out of the brain. That is what it is doing. It is telling the immune system to target these amyloid plaques and remove them, to have those immune cells go ahead and eat those plaques and get rid of them out of the brain. So how is it administered? Well, it's an antibody, so you can't take it in a pill by mouth. It has to be infused. And it's infused over about 1 hour at an infusion center. So you have to go to some place and get an infusion. And you have to do that every 2 weeks. And right now, we're going to treat people with lecanemab for 18 months. So every 2 weeks at an infusion center for 1.5 years, and maybe longer, depending on whether your amyloid is cleared at 18 months or if we have to continue to treat. So that is the current paradigm. Now, I will say that pharmaceutical companies are working on trying to get this into a form where it can be injected under the skin, like insulin. That would be a lot easier, wouldn't it? To not have to go to an infusion center every 2 weeks to get this medication, if you could just do it at home and inject it yourself. But that's not here yet, but it will be someday. All right, so that's what we're talking about. We're going to an infusion center. These are places that give medications for many different reasons. There are antibodies that are given for certain types of arthritis, for instance, or cancer treatments, or chemotherapy. So that's what one of these places is. You go, you sit into a chair, you get an IV, they hook it up to a saline bag, and they infuse the medication over it. Okay. So does lecanemab help with your memory? All right, so we're going to get into now talking a little bit about the clinical trial that showed that lecanemab was effective. So in the clinical trial, the main outcome measure to measure the effectiveness of lecanemab was something called the CDR sum of boxes, Clinical Dementia Rating Scale sum of boxes. So what is this? This is a composite measure that takes into account someone's memory, orientation, judgment, problem-solving skills, their ability to participate in community activities and activities at home and their hobbies and taking care of themselves. It rolls all of those things up into one measure. And that's what was used to say whether lecanemab is effective. So we're not here just talking about your memory, cognitive function. We're also talking about your functional activities, things that you do every day on a daily basis. So this is a scale from 0 to 18. 0 is normal. 18 is the worst. That's the most effective, severely impaired cognitive and function. So what did lecanemab do on the CDR sum of boxes? So this here, what you're looking at on the right is a graph. In the filled boxes in the solid line are the patients that started the trial on placebo, so they didn't get the medication, and were followed for 18 months with placebo infusions. This is the months here, 0, 3, so forth to 18. There was about a little over 700 patients in this placebo arm. In this line, the dotted line, represent the patients who were treated with the medication, lecanemab, and about the same number of patients over the same time frame. And you can see that the curves are different over 18 months. By the end of 18 months, there is a significant difference between the placebo group and the lecanemab treated group. So that difference, I will put your attention here on the left. Here is the mean change from baseline. So just say you start at 0. And the change here between this group and this group was about 0.4. 0.4 on this scale of 0 to 18. All right, that is the effect that we saw in this trial with lecanemab over 18 months. What does that mean for someone in their everyday life? Well, it's a change, but it may be a fairly small change, something that may be somewhat hard to notice for many people. Maybe their families would notice it more than the patient would, actually. Some people may experience a significant change in the way that they perceive their memory or their functional abilities. Some people may not. But statistically, if you take everyone together, there was a significant benefit from the medication in that measure. Another way to look at this is to look at when would this curve meet this curve. So if you extrapolated this one all the way out and you went down here, what is the difference in time between this point and this point, theoretical point out here? And that is about 6 months. So in other words, if you were treated with lecanemab, you could expect to delay the progression of your symptoms on average by about 6 months compared to placebo. That's another way to look at this measure, okay? The other thing to note about this was that this was only for people who started here, right? So these are people that were mildly affected. They have mild cognitive impairment or mild dementia. These were not patients who started in the middle. They did not have moderate or severe dementia. They had to be in the mild stages of the disease. That is where the effect was shown, because that is the trial population that was tested. That's important to note. So when you do clinical trials, you get a measure that, I'm gonna just minimize this so I can make sure people can see. You kind of give this total average overall measure. Did the drug work or not, right? In the treated group or not? But it turns out that there's a lot of complexity underneath that treatment group or in the placebo group that is actually treated. So I'm going to show you this. This is a lot to look at. This is just to give you an idea that, that there may be some variability in how certain people could respond to the medication. So we'll start at the top. And what you're looking at here is the difference in this scale we talked about, the CDR, sum of boxes, versus the placebo. So we want to see negative numbers here. Negative is good. Everything to the left of the dotted line here is a benefit. Everything to the right is harmful. So overall, in the population, we saw that there was a difference of, like I said, about 0.4, 0.45. And that's a 27% slowing of decline, 6 months over 18 months. Now, if you look at people that have this genetic change called ApoE4, this is the strongest genetic risk factor for Alzheimer's disease in the general population. And people that didn't carry this risk factor at all seem to do pretty well, maybe even a little better than the average of 0.45. People that carried one copy, called the heterozygotes of this ApoE4 change, genetic change, they did okay. about average, people that carried 2 copies of APOE4 did not appear to do as well as the other group. In fact, maybe there was a little bit of a trend towards worsening medication. Although we can't say that for sure because this crosses the line. So it's statistically we cannot say. But this is to show you that APOE4 genotype may matter in terms of your response to the medication. How about if you're a man or a woman? Well, in this trial, men seem to do a little bit better than the women did. People that were slightly older seem to fare a little bit better than those who were younger. Now, we don't know why that is, but it seems to be that people that develop the disease before the age of 65 tend to have more aggressive disease. So that may be one reason. Not necessarily that the medication is less effective, just that maybe that their disease is more severe to begin with. But that was the trend that was noted. What about your ethnic or racial background? Well, if you look at, here's the global data, and then just in the United States, there seemed to be a good response in Hispanic or non-Hispanic groups, white and Asian. Now, in African Americans, there seemed to be, on average, a good response, but there were so few African Americans in the clinical trial. That is why these error bars are so large. We can't say with statistical confidence that there was a strong effect in African Americans just because there were so few in the clinical trials, unfortunately. And this is a problem. And Dr. Parker can tell you a lot more about the issues that go into good representation in clinical trials. But this is to say that we think it will be effective in African Americans, but we don't have a lot of evidence to say that. And that's the case globally and in the United States. Okay. So what is lecanemab going to do for you? Now, remember, I talked about the CDR sum of boxes. It's a composite measure that talks about your activities, things that you do every day, talks about, your ability to remember things, process language, to navigate around the world, your orientation, to pay your bills, your executive function, keep track of things like that, do more complicated activities, remember people's names. These are all important activities. But what we want to communicate here is that we're not going to be able to tell you if this is going to help with a particular cognitive problem that you're having. Right? If the cognitive problem that you're having is what brought you into the clinic, well, it's probably the case that lecanemab will have the most effect on that particular problem. But again, we don't have enough information to say what exactly it's going to do for a particular cognitive issue. It's a global thing that we're looking at with that CDR sum of boxes. Okay. So who should be treated with the medication? Well, I'm going to repeat this. This is indicated for the treatment of Alzheimer's disease. And as Dr. Parker mentioned, there are other causes of dementia. Alzheimer's disease is the most common cause, but people come into the clinic with many other causes of dementia. So we have to make sure that you have Alzheimer's disease before you get treated with lecanemab. That is an absolute requirement. And not only that, it has to be Alzheimer's disease in the mild stages of disease, not in the moderate or severely affected stages. So that's what we call MCI. So MCI being that you've noticed some problems in your everyday life, or maybe others have also noticed. And we can document those on our clinical exams and our cognitive testing, but you're functional. You're able to take care of yourself. You can go about your everyday activities. And then mild stages or mild dementia, meaning that you're starting to need a little bit of help with some of the things you used to do by yourself. That is what lecanemab is. That is the stage of disease where lecanemab is indicated. So the other thing that is important to know is that in the clinical trials of lecanemab, even if patients were in that stage of disease, MCI or mild AD, They could also have been excluded if they had other exclusion criteria, and we'll talk about what those were. But this is also important to note that there may be reasons, even if you're in the mild stages, that you could not be treated with lecanemab because of other issues in your medical history or in your personal situation. So you have to be between the age of 50 and 90 because that is the trial population that was tested. So if you're over 90 years old, then you do not meet the inclusion criteria for the medication. You have to be within this age range. You have to have mild cognitive impairment or mild dementia with biomarker confirmed Alzheimer's disease. It cannot be just a clinical assessment. It has to be documented that you have amyloid in the brain, that either through a spinal tap, a lumbar puncture, or some other kind of assessment, like an amyloid PET scan, all right? Otherwise, the drug's not gonna work because there's no amyloid there. You have to have amyloid in the brain. You have to have mild cognitive symptoms. You have to be independent in your basic activities of daily living, dressing yourself, bathing yourself, eating, and maybe at the most minor impairments and more independent activities of daily living, like driving or paying your bills. You also have to have an MRI of your brain and other laboratory studies that don't exclude you from receiving the medication. And that is to say that if you can't get an MRI for whatever reason, you are not going to be able to be treated with lecanemab. And that is because we will need to monitor people on the medication for safety reasons with an MRI. So sometimes people cannot tolerate MRIs because they don't like to lay in the tube in very claustrophobic conditions. They just are not able to do that. We can help with medications if that is an issue. That's not an absolute exclusion. We can provide people with some medications to help reduce that anxiety. There are other reasons why people can't get MRIs. For instance, if you have ferromagnetic metal in your body, that is not a good thing to be in an MRI scanner for that. Sometimes certain pacemakers cannot be in an MRI, right? So if there are certain types of hardware in your body, you may not be able to get an MRI. If that's the case, you're not going to be able to get lecanemab. Now, sometimes we can see on MRIs that people have had some bleeding in their brain. That is something that's important to note because if that is too severe, then that's going to exclude you from receiving lecanemab, and we'll talk about why in a minute. Also on MRI, sometimes we can see that there are other reasons why someone has cognitive impairment. For instance, if they have a lot of vascular disease. They may have some amyloid in the brain, but it could be really due to the vascular disease in the brain that's causing the cognitive problems. If that's the primary issue, then it's probably not worth the risk of taking lecanemab because there probably will not be much benefit from receiving the medication. You cannot have unstable, severe psychiatric illness in the past 6 months. That was part of the enrollment criteria in the trial. Uncontrolled risk factors like diabetes or hypertension or end-stage kidney disease. You can have a history of having a bleeding disorder where you don't stop bleeding, you don't form clots. You can have cancer that's being actively treated. And this doesn't necessarily include hormonal therapy for things like breast cancer, but it includes, chemotherapy for other types of cancers. Also, other diseases that might require you to be immunosuppressed, right? So we're talking about things like multiple sclerosis or, certain types of rheumatoid arthritis or lupus, things like that. And then I will repeat, patients who are too impaired. This is the biggest one, right? You cannot be too impaired, too advanced in disease course in order to receive lecanemab. All right, so now we'll get into a little bit of the details on potential side effects of the medication. Remember, we're talking about benefits versus risks, right? So I showed you the benefits. Now we're talking a little bit more about the risks. So when you get a medication, you go to the pharmacy, you buy, you could buy or get it from the pharmacist. The pharmacist gives you the medication that comes with an insert. This is required by the FDA. It has to be an insert with the medication. So you take that insert out, you open it up, it's about this big, double-sided, in 5-point font. You can hardly read it, right? And it has all the information on there about the medication, from what we've known about it in the clinical trials, from what the FDA wants to provide you in order to determine a risk versus benefit. So this is something that would be on the label. What are the adverse reactions that can happen with this medication? So the most common one is infusion-related reactions. So what does that mean? Well, an infusion-related reaction is usually something that happens while you're receiving the medication. So I'm not feeling well. As I'm sitting there in the chair and the medication's going in, I'm getting a rash, I'm feeling nauseous, a little lightheaded, I have a headache. These are, I'm kind of swelling up a little bit in the arm. These are typically what we call infusion-related reactions. And we can oftentimes treat these types of reactions with, say, giving someone Benadryl or something like that before getting the infusion. That even happens when people get placebo, by the way, 7% of the time, not just the medication. And then there are these two ones, ARIA, H, RAE. We're going to talk about these next. I'm going to skip over here. I talked headache, superficial cirrhosis of central nervous system. That kind of falls into this ARIA H. We'll talk about that. Okay. So a lot of these weren't that much more common with the medication than they were placebo. All right. And then they're not common to begin with. Some of these, like a rash, 6% versus 4%. All right. It's not a common problem, but this is the potential adverse events. So let's talk a little bit more about the most important ones related to the safety of lecanemab. So this will be also on the label. Warning, amyloid-related imaging abnormalities. That's what this stands for, ARIA. Amyloid-related imaging abnormalities, -H. H means hemorrhage, means bleeding. -E means edema. Edema means swelling or too much water in your tissue. Okay, this is the warning. So this medication and monoclonal antibodies like it can cause ARIA, usually asymptomatic, meaning it doesn't cause, you don't notice it, but can cause serious and life-threatening events, right? And ApoE4 homozygous, those are the people that have 2 copies of ApoE, have a higher incidence of ARIA compared to people that have 1 copy or no copies. So caution about people that have 2 copies here. This is why we're going to require genetic testing for ApoE4 before people receive the medication, so we know what the risk is going into it, right? Are you a carrier or not? If you are, how many copies do you have? If you have 2 copies, we're going to need to monitor things more closely to make sure that things go well and that people are treated safely. So what is ARIA-E? ARIA-E means ARIA-edema. So this is an MRI scan of someone before being treated with lecanemab. And this is someone with an MRI scan after being treated that has developed some ARIA-E. And the difference is right here. And that is what we see on the MRI. And that is where there is some inflammation now in that part of the brain, some changes in the tissue. This is, you can kind of think about it maybe like if you have an infection in your hand or something like that, your hand will swell up a little bit, right? You'll get some edema there. You get some water in the tissue. Your immune system is changing your tissue there to help fight that infection, and you're getting some swelling. So it's kind of the same thing in your brain. You're telling your immune system to clear the amyloid plaques. Okay, so it does, but as sometimes when that happens, you get some swelling. some edema, some water in the brain. We can see that in the MRI. And we don't want that to get out of control, because if that gets out of control, that can have very serious consequences. So we need to monitor that very closely. That's ARIA-E. ARIA-H. ARIA-H stands for hemorrhage. Like I said, we can see blood in the brain. So that's these little black spots here. That's little spots of blood. And that can happen even if people don't get the medication, but the medication can make that worse. And we do not want to introduce blood into the brain because blood is highly irritating to the brain. All right, so we will want to try to avoid that as much as we can. Sometimes, in rare instances, this can get really bad. All right, this is a case that had ARIA-E and ARIA-H, and you can see how much edema and hemorrhage there has been in this particular case. This was the autopsy on that brain. You can see all the blood there. If you look closely, you can see that there was a lot of inflammation around the blood vessels, a lot of problems, blood and amyloid deposition in the vessels. So this is something we want to avoid as much as we can. This is the risk. This is what we're talking about, risks. ARIA is the biggest risk. So it's important to note here that ARIA can happen. How often does it happen? Well, if you take all comers, all cases of ARIA, and in this trial that was used for approval of the medication, 4% of the people on placebo developed ARIA that didn't have the ApoE4 gene, and 13% on lecanemab developed some form of ARIA. Now, as you have more copies of ApoE4, the more likely it is that you will develop some ARIA. That is the case whether or not you receive the medication, by the way. Placebo people have some ARIA if they have ApoE, 2 copies of ApoE4, but that is doubled, right? If you essentially doubled risk if you're being treated with lecanemab. So should you be concerned about this? Should we be concerned as providers? Well, the answer is yes, but we have to put it into context. And here are the rates of symptomatic ARIA. So we can see ARIA on an MRI scan, but is this something that you would notice in your everyday life? So symptomatic ARIA edema, for those who didn't have any copies of the ApoE4 allele, that rate was 1.4% of people had symptoms from the ARIA. So for many people, we could see it on the MRI, but they didn't notice that they were having any problems with it, okay? That goes up, again, as you have more copies of ApoE4, the more likely you are to have symptoms from ARIA. The symptoms from just ARIA-H were less common, but it turns out that usually these two things go together. You'll get ARIA-E and ARIA-H accompanies ARIA-E, less common just ARIA-H, okay? So what does this mean? Well, it means that we need to monitor for ARIA and we have to be careful about it. But for many people, they will not notice if they have any symptoms, even if they do develop some ARIA, okay? So how do we deal with this risk of lecanemab? Well, this is the rubric that we're going to follow on how to manage that risk. So here on the left are the clinical symptom severity, asymptomatic, mild, or moderate severe symptoms. And then on the top here are the imaging findings, right, from ARIA, mild, moderate, severe, based on the imaging criteria. So if you have mild ARIA on an MRI, but you're asymptomatic, it's probably okay just to continue dosing every 2 weeks as we are and monitor this. If you're having some mild symptoms, but the ARIA is mild, the recommendation would be that use the clinical judgment on whether or not to proceed. Maybe you would, maybe you wouldn't, all right? Depends on the situation. If you're having a lot of symptoms, even if the ARIA is mild, stop the medication at that time and see how things go. See how the symptoms go. Now, that changes if the ARIA looks worse on an MRI. Whether or not you're having symptoms, if it's starting to look bad on an MRI, stop. All right, we have to stop. We have to make sure that that is not going to get worse and that ARIA is going to resolve. And it's going to resolve over time. All right, so that's how we're going to approach managing the risk of ARIA. How else are we going to minimize risk? Well, some people, I told you that there sometimes can be blood in the brain, right? So what if you're on a blood thinner? Turns out that people that were on aspirin or other blood thinners like Plavix were fine in the clinical trials. They didn't have any increased risk of bleeding in the brain. So it's probably fine if you're on an aspirin or Plavix. However, if you are on anticoagulation, what I mean by that is Coumadin, also known as warfarin, or things like apixaban or Eliquis, we need to be careful. These people were still allowed to receive the medication in the trial, by the way. But there is a risk for having a severe bleed in the brain if you are anticoagulated. And that is something that we have to be very cautious about. Okay, so right now it is not an absolute contraindication to receive the medication, but it's going to depend on the clinical situation. And I think many providers would be hesitant to treat people with lecanemab on anticoagulation at the current moment, at least until we get more experience and information about this potential risk. Okay, in some of the very severe cases where people passed away, they were on anticoagulation. Okay, so we just have to be careful. We have to be careful about that. All right. Well, we're getting to an area now that I am not an expert in, because most physicians don't know anything about what things cost in medicine, unfortunately. But I will tell you what we do know. And we do know that in order to receive the medication, you're going to have to participate in something called a registry. What is that? Well, that means that you're going to have to be monitored. Your information is going to have to be entered into a database, either here at Emory or with Medicare, in order to track what the medication is doing over time. Medicare wants to know how this medication works in the real world, right, of Medicare, the Medicare population. So they are going to provide coverage for the medication with the provision that we provide information back to Medicare so they can see how it's working. So we will be able to get people into a registry here at Emory, either through Emory or through Medicare registry. As part of Medicare, there's usually a 20% copay for medications. Sometimes people have co-insurance that covers part of that, some people don't. What does lecanemab cost? Right now, the cost for this medication is at $26,500 a year for the medication only. What are the other costs? Well, there's a clinic visit, there's the MRIs, there's the infusion centers, there's the blood tests, there's the testing. It's all this other stuff that goes into that that's additional to the medication. So what does a 20% copay mean on this? Well, it might mean between $10,000 to $20,000 a year. And that may not be per year, but at least to start with all this other stuff. So this is just to say that you're gonna need to look into coverage for you, depending on your insurance coverage, what kind of insurance you have, what the copays would be for that, okay? But there is going to be some cost to the medication. It could be substantial. How long do I need to take it? Good question. So for most people, this is not going to be a lifelong therapy, we think. Why? Because it slows down progression, but it doesn't stop progression. So if we're treating people in the mild stages of disease, and they slowly progress into more moderate to severe stages, the medication at that point is likely no longer to be of use or help. And so at some point it becomes not worth continuing to treat, right, with the medication. So there will be a window where people will be treated with the medication. If people are having severe side effects or not tolerating the medication, then we would stop the infusion. Like I said, people who progress to the disease, more advanced stages of disease. And also, we are still waiting to get more information through our studies to see whether or not we need to continue with maintenance therapy, right? So in this trial, what happened was people were treated with lecanemab for 18 months, and the vast majority of them, the amyloid was gone in the brain at that point, right? But if you stop the medication, does it come back? Do you need to continue to treat with lecanemab? So the preliminary data right now says that it does come back slowly over years. Now, so how often then, if we want to make sure that we keep the brain clear of amyloid, how often do we have to treat? That's still an area that we are getting more information on. Maintenance. What, if any, maintenance dosing do we need to do? All right. So unlikely that you'll be treated every 2 weeks for the rest of your life, but it could be the case that if you are progressing very slowly on the disease course, which is what we want, that you may need maintenance therapy, say every 3 months or every 6 months or every year, as you go forward. We don't know yet. So to summarize, what lecanemab does is it removes amyloid from the brain, and that seems to have a significant clinical benefit. People still get worse over time, but at a slower rate. How meaningful is the effect after 18 months? And will the effect increase or level off after 18 months? Right? This is a bit of a debate in the field. Clinical meaningfulness, right? It's like I said, the CDR, that measure, that's a small change, but important. And over time, does that change get bigger? Right? Do those curves continue to separate? There are potentially serious side effects that we have to be careful with, we have to monitor. And the medication is costly, even with some coverage. And you have to participate in a Medicare-approved registry. For those people that are not on Medicare, how is this going to work? We don't know yet. This is something that we'll have to work with individual insurance companies. Oftentimes, they will follow Medicare's lead on what is covered and what is not covered. But we want to make sure for any individual patient that we know what that coverage is going to look like if they're not in Medicare. All right. So it's every 2 weeks at an infusion center. We're going to have to schedule this in advance, right? So this means that you're probably not going to go on that trip to Europe for 18 months, right? This is something you're going to have to get an infusion every 2 weeks at a place that's scheduled for you. You can continue their current medications if you're on them for Alzheimer's disease. That's fine. So risk benefit, again, we're back to risk benefit. That's going to depend. It's going to vary between patient to patient. We have to make sure that we're following the criteria that were outlined in the trials to minimize the risk and maximize the benefit. And quality of life needs to be central in the decision-making process. And this is it's new for patients and providers. So we're all learning as we go through this new medication. It's a very exciting time. This requires a team approach. And like I said, this is an individual decision made in consultation with your healthcare providers. So what may be right for one person may not be right for another person in a very similar situation, depending on patient preference. Okay. So I'm going to stop there. Let's see where we're at with time. We have a few minutes. So I know I see some questions in the chat, and see if I can open that up. You did, okay.
Dr. Johnson, would you tell people who's gonna be managing this? You talked about infusion centers. You're my neurologist. Are you gonna be the doctor that gives me
Yeah.
this medication?
That's right. So this is a medication that's prescribed by a physician and administered in an infusion center. And it's going to be, right now, it's managed mainly by people like me, cognitive neurologists or geriatricians. It's not going to be prescribed by your general practice family care doctor.
So what about people who are participating in research? You know, we have drug trials here. Lecanemab is one of the drugs that has been one of our drug trials. Are there other drug trials? Can we get involved in them? How would we do that? 'Cause
Right.
if you're in research, drugs are free.
That's right. So
Just saying.
we do run clinical trials here at Emory. We want people to participate in clinical trials so that we can learn and develop better treatments for Alzheimer's disease. So this is going to depend on the clinical trial. This is going to be a medication and others like it that are coming in the pipeline that many people are going to take, right? So our clinical trial operations are going to have to adapt to the reality of lecanemab and other medications, other antibodies that clear amyloid from the brain. And this is going to depend on the particular clinical trial, the sponsor of the clinical trial, what they want to do, what are going to be the inclusion and exclusion criteria for that particular trial. So you can still participate in research if you're on this medication, but the study that you can participate in may depend depending on the sponsor.
What about concomitant drug use? I assume that you would not be able to be on Aricept, memantine, anything like that at this time.
So the question is, can you be on other medications for Alzheimer's disease and lecanemab? And the answer is yes. You can be taking donepezil or memantine and lecanemab together. That is not a problem.
Just a second, she's gonna bring it back.
If what you describe, what you're hoping for, is that it will eliminate the plaque for a certain time and then you can do a maintenance. If that works out, I can see this as a great medication. But the tests seem to show that it only slows the progression for 6 months, which, and if that's all it does, then I don't see much advantage to it. So I want you to continue to test.
Right. Yeah. So that again, getting back to the individual choice, right? What may be important for one person may not seem important for the other person. So 6 months to someone may be very important. 6 months to another person may not mean much of a difference. The other thing to say about this is that that's an average of everyone who was treated in the trial, right? So I showed you that maybe some people respond better and some people respond worse, depending on your particular situation. So on average, it's 16 months, but for some people, it might be more than 6 months. Sorry if I said 16, 6 months. Yep.
Mr. Graves, hold on, run into the mic.
Does the person get a PET scan or MRI before it's determined that they should be taking this drug?
Right. So we have to be able to document that there is amyloid in the brain before you can be treated with lecanemab. That's either with a lumbar puncture, spinal tap, or a PET scan. You can have either one. Either one works. Now, for monitoring the medication over time, we're in most cases going to use a PET scan to see whether the amyloid is removed or not. And if it's not removed by 18 months, we'll continue to treat for some period of time until we can see that amyloid is removed. And we'll make most of those assessments by PET scan. And that's something, like I said, that Medicare will likely cover as part of the being in the registry study. Right now, Medicare is not covering PET scans for screening to see if you have amyloid in the brain, or nor are private insurance companies.
Second part to that question. Now, if the plaques are being removed over the next 18 months, and it only slows the progression for 6 months, does that mean the amyloid will come back?
So based on some data right now, it looks like amyloid does reaccumulate over time after 18 months. Say someone was cleared, in 18 months it's gone, your brain is squeaky clean, no amyloid there. It does appear that over time, and we're talking years, that amyloid will reaccumulate. But I don't want you to confuse that between this 6 months kind of extension of or slowing of progression. The idea is that even if you clear amyloid completely at 18 months, people still on average continue to worsen over time, and the time that you delay symptoms is about 6 months compared to someone who didn't receive the medication, even if the amyloid is completely gone, right? And it's not coming back within 6 months, right? It's gone 18 months, 24 months, probably even longer. People still continue, and that's because there's more going on in Alzheimer's disease than just amyloid. We think it's an important part of the disease, but it's not the only aspect of the disease. And even if we clear amyloid completely from the brain at this mild stage of disease, it doesn't stop disease progression. Now, if we were to treat even earlier, say before people even have symptoms, but they have amyloid in the brain, would that make a bigger difference? Maybe. There are ongoing studies looking at that question, but we don't know yet.
Just to add to that question, Dr. Johnson, one of the questions was, if I have plaques in my brain but can I not have Alzheimer's?
So, yes, you can. This is getting a little bit splitting hairs, but as we're in the context of lecanemab, right? How we're defining the disease currently, you have to have amyloid in the brain, and you have to have some kind of symptom. Now, we know that people have amyloid in the brain many years before they develop symptoms. So why wouldn't you want to try and do something about that much earlier? Well, conceptually, we would want to do something about that earlier, but we haven't shown yet in our studies that treating before people have symptoms makes a difference. So, in other words, in the future, we may be able to treat people before they have symptoms, but right now, you have to have some kind of problem, some kind of symptom, and amyloid in the brain in order to receive lecanemab, and that is how operationally we're defining Alzheimer's disease right now.
Let me just answer this. We're going to have just one question here and one from the audience. Read this one for me.
The question is it readily available currently? And generally, how long from the initial appointment to first infusion? Right. So the medication is currently on the Emory formulary, which means that it can be prescribed today. Now, logistically, like I said, there's a lot more that goes into receiving lecanemab. So you have to have all the screening studies done, right? And we have to make sure that everything is safe and that you meet the inclusion criteria. And then you have to go to an infusion center and get the medication. So it takes some time before we can actually deliver the medication. But the bottom line is, yes, it's available now. And if you meet inclusion criteria, we can prescribe the medication and you can receive it in an infusion center somewhere in the Emory healthcare system. Okay. And then there was a question about Medicare Plus supplemental insurance. So, right. Again, this is something that I am not an expert in. You're going to have to go in and you're going to have to talk to the insurance company that you have and see what is covered and what is not covered with lecanemab. So the medication itself and all of the other costs associated with receiving the medication. So that's going to vary between individuals and their insurance companies, insurance plans.
Well, first of all, thank you for being so slow and so precise. It was really very helpful, and I've taken copious notes. But let's say I decide to find out if I have amyloid plaques, which I think I probably do have some, a few or two, okay. Or however you count them. And then I go through this process and I pay about 30 grand and I've used my 18 months and I'm like, I've had it now. And so what's the difference between amyloid and a senior moment? You know, we've talked about a senior moment. You know, we talk from when I was a little girl, oh, grandma's having a senior moment. Or, you know, this is just aging. This is just the process of aging, which it seems like we can't quite accept sometimes these days. And we won't get into the philosophy of it, but it seems like in order to really do this, instead of having the haves and the have-nots, that there just needs to be a lot of big samples, and it needs to be a whole lot less of expense tied into it. Because so many people don't even have access to transportation that could get people there to all these tests and things. That's just an aside. But what would be? So I went through all of this and you tested me, no amyloid. And then I started having my little senior moment and I go, it's back.
I want to make sure I'm very clear about this. In order to receive lecanemab, you have to have documented cognitive impairment.
Well, I could probably do that pretty easily.
So what does that mean? That means that you are coming to see a physician and you are being evaluated by a physician with cognitive testing, formal cognitive testing. This is not, we're not talking about senior moments. You know, we're not talking about that. We're talking about, I'm concerned that, or my family's concerned that I have a problem. And I'm here in your office to see if I have a problem. And we're doing a formal evaluation. And if you have a cognitive problem and you have amyloid in your brain, now we're talking about potential treatment with lecanemab. But we're not talking about, you know, senior moments on the offhand. Now, again, if you think that you're having a problem that is concerning to you or your family, then you should be evaluated, because the earlier you're evaluated and the earlier we could potentially treat, we think the more likely you are to have a good outcome with something like lecanemab, right? But this right now is not meant to be given to the general population.
I understand that. I was just sort of concerned about how after the fact are you, I don't know. I mean, what stage then do you pick up another 18 months or another you know, session of all of these? I mean, just till your money runs out?
Yeah. I think this is a really good point. Thank you so much, Dr. Johnson, for taking your afternoon to spend it with us. Thank you. This kind of brings us to an end for this program today. And for those of you here who are interested in participating in the research that's offered here at the Alzheimer's Disease Research Center, we have some of our intake team. Clark, if you're interested in research, please let Ms. Clark know, Ms. Gilchrist, that's her name, and she can tell you what we're going to do to get you involved in some research here. There are a number of different studies here. We study people who have no symptoms of Alzheimer's. We have people who have mild cognitive impairment. And then we have people who do have dementia, who are generally under the care of a doctor, who are participating in several of our clinical drug trials. We welcome you back here next week, Tuesday from 2 to 3. And again, we hope to see you at our Carter Center Brain Health Forum in October on the 24th at the Carter Center. Thank you so much for joining us. Yes, ma'am.
6 months. Okay, we buy ourselves 6 months.
Yeah, so I can talk about, so this one is. Available now.
Long enough to get real help.
That is developed as we go along. It may be, Alzheimer's may be treated the way we treat HIV. It's a combination of medicines. Right now, we have 2 medications that have been approved by the FDA. As we go along, it may be a combination of medications that eradicate Alzheimer's. Okay, so the question you ask is a really good one. But the other part of that, the answer to that question is really, we don't really know. Right, there's continued research.
You said there's a drug right here. We're not gonna use it.
There should be, there's some over here. I may have some left over. If you wait a little
There are over 136 clinical trials, drug trials going on in the United States and around the world at this time.
For how many different trials?
I said there are 130 some trials of different medications. I don't know the names of all of those medications, and he doesn't either.
This is not the end of the road.
No, this is not the end of the road. That's why I was likening it to HIV infection. We're at the beginning of this. So if you look at HIV infection, okay, and I was in medical school when they started talking about HIV infections and AIDS. And here we are, 30 plus years later, we have a definitive cure for HIV. There's a lot of trial and error, a lot of people have died from the disease. But now, here we are 20 years later. Get it non-transmissible. There are medications that make it non-transmissible. Perfect example, Magic Johnson, the basketball player, is living with HIV. He's not dead, he doesn't look incapacitated, he doesn't look sick. But he's on a combination of medications that have kept his symptoms away. And that's what we're hoping is gonna happen with Alzheimer's.
So that's why I was asking about that. Research.
You need to go back there and tell them how much you love them. We have to put our posters up for a rock star. Go tell them how much you love them. I know Lynbrook, my aunt lived right next door at Renaissance. And we have several patients. I've had several patients.
We got Marty.
I don't see, my aunt lived at Renaissance for like 20 years before she died in 2021. And they just built her 100 towers over there on Lenbrook side and on the, what's the other one? Canterbury Boulevard.
What I want to ask you, could I have several copies of this to take back to Lindbergh?
Take all you want. Take them all. Go on ahead and collect them. Go ahead and take them. But I've seen you there before. Don't you come to the, aren't your husband or somebody in your family volunteer or was?
No, we've been in since 18.
Right.
My husband was,
Well, then I'll-
my husband, we were in since 18. He was 89, had MCI. Dr. Law was testing him, further testing him, because he couldn't determine. But he was
You want to know
really,
when
really
you make a
smart.
difference.
Take some fruit home, please.
Right.
Please, please.
Dr. Law was regained his brain and spinal cord.
But see, I remember it from the memory.
Oh, yeah, well, that's what Dr. Law said. This is a real problem, my husband. And they did find
We all
Alzheimer's.
volunteer for our
I'm a
research.
super agent. I'm a super agent.
You are, you're one of our super agents.
Yeah, I
Good.
love it, I love it. Anyway, they did find Alzheimer's, in his brain and spinal cord. But Dr. Law didn't tell us the progression.
But you were there.
Yeah.
Thank you for coming.
Supportive community in a non-existing.
Okay. Oh, it's for Dr. Okay, so yeah, I'll respond to that. That's okay. So I'll respond. Them just respond to while you were writing. So I'll respond to that. Thank you. All right, no problem. Does anybody? Somebody asked. Yeah. Please. Did you want to go? You're part of it. Don't be shy. We see you.
No.
Hello, my friend. Hello. How are you? I have not forgotten. You know, I'm doing your screen for myself. I have not forgotten about you. You're on my list. That's why I wanted to call you because I said I want to. So I'm gonna do yours myself. Let me just get slowed down here. I'm gonna call it just like Monday or Tuesday. Is that a good day? You go and push down. I'll be right back. Nice to meet
I've only been to one person. Oh, you?
I'm semi-retired, so, but I like to.
Then I was with the Carters.
Yeah.
I had a little, I didn't have a full criteria, but I did have.